Next slide, please. So here I would like to make a distinction that shapes everything else I will say today. The distinction is between the lifespan, as you see on the slide, and the health span. Lifespan is very simple. It's a biological term. It is how many years we live. Now, health span it's very important and it's different. It's how many of those years we live well, with energy, with strong body, with clear mind, and free of disease. And health span is the real goal here. So let me maybe put it in human terms. For many people, let's say the last year of life are spent in poor health, living with a disease and often losing independence. So health span is about shrinking that gap. It is about arriving at 70 or even 80 with good health and strong, still active and still yourself. Next slide, please. So we are going to visit the 3 pillars of my presentation. The first pillar is hormonal balance and menopause. And it is very important because women really don't understand when they enter that stage. And it's sometimes, and not sure the audience, I don't see how old are you guys, but anyhow, it is very important for a woman to understand when she enters the perimenopause, the menopause, because hormonal balance is the most important thing once we get to the age of 35 or 40. So again, we will look at 3 pillars in hormonal and balance and menopause. Second will be proactive weight management. So that's your body composition that changes after 40. Third is the disease prevention. That's the heart, the bones, and metabolism. And running through all 3 is one thread: personalization, how we take strong evidence and turn it into a plan built around one woman. Well, let's start with what actually changes in the body. Next slide, please. So after about the age of 40, 4 system begins to shift at the same time. No, go back. Yep, stay here for now. So yes, 4 systems, these are 4 systems, they are beginning to shift at the same time, and understanding them removes a lot of confusion that women usually have. So the first shift is hormones. As we can see, estrogen and progesterone, they begin to decline at about age of 35. And as you will see, it's going to affect every system and every part of the body. The second is muscle and metabolism. We slowly lose lean muscle. And our resting metabolism, the energy we burn just by being alive and sitting doing nothing, gradually falls. The medical term for that is sarcopenia, is when you lose the muscle. The third is fat distribution. Fat begins to move towards the abdomen and around the organs at about the age of 40. This kind of fat carries very important risks. And the fourth is the bone. Bone loss speeds up at the years surrounding the menopause. Now, these are the general patterns. I don't want you to be afraid to get scared, because the pace of these changes varies greatly from a woman to woman. And 2 things that shape the pace is our biology, your daily habits. The biology includes genetics, of course. And so the daily habits is the one that we can actually act on. So when you see the slides, again, please do not think of this as a bad news. It's a map. Each of these 4 systems has set of tools that protect it. And as you will see, many of those tools, they will overlap, and we will visit this. So one good habit often protects several systems at the same time. So, and that's the most important idea on this slide. These changes are connected to one another. So the hormones, the muscles, the fat, and the bone, they're all connected to one another. And most of them are modifiable. We can influence them with our daily habits, and that's a very good news. Next slide, please. So we're going to begin with the pillar 1, and the first pillar is hormonal balance and menopause. So the simple way forward, please. Yes, hormonal balance and menopause. Estrogen, so I want you to understand that estrogen is not just a reproductive hormone, it's the whole body hormone. So when it declines, the whole body notices. Next slide, please. So, and let me show you just how wide estrogen's influence is. You see, we have these 6 systems or 6 examples. So first, estrogen is cardioprotective. It supports cardiovascular system. It keeps your blood vessel flexible and helping maintain a healthy cholesterol profile. Also skeletal muscle, so estrogen does support the skeleton, helping to keep bone dense and strong. Now it also influences cognition, your memory, your focus, and how the brain uses the energy. It affects metabolism, including how sensitive we are to insulin and where the body stores fat. It's also linked to mood and sleep, and it supports skin and connective tissue, collagen, hydration, and elasticity. So when women describe many different systems at once, change in sleep, in mood, in weight, in memory, these are not separate problems, even though conventional medicine, of course, they look at that from the separate perspective, but they all have, it's not a separate problems, it's one root. They all have one root, and there's something important hidden in this. For years, many of these symptoms, again, as I said, were treated separately or too often dismissed. A woman would be told that her tiredness, her mood, her weight, and her sleep were not related to each other. But now we know that they are all related. So all of this shares the one hormonal root. And when I see women in my practice, I find that many women, they feel relief just by simply understanding this. It means they were not imagining those symptoms. It means that a single strategy can improve several of these areas at the same time. And that's exactly why a coordinated approach works better than treating each symptoms alone. It is far more helpful place to begin. And one example I can give you is, for example, I have a patient, perimenopausal patient, who cannot sleep, who has mood swings, who has weight gain, and she goes to her doctor, and the doctor would say, you need to go to psychiatrist because of your mood and because of your sleep. But if that practitioner would understand what menopause does to perimenopause does to women's health, he would say, you don't need to go to psychiatrist. All you need is to take progesterone and estrogen and testosterone. Now, of course, all these hormones have to be balanced. So this is the one example. Next slide, please. So yes, people often speak about menopause, as you maybe remember your grandmother or your mother, as a single moment. Oh, I have a menopause, or I'm entering the menopause. But in reality, it is a journey. It is a journey in 3 phases, as you can see on this slide. The first phase is perimenopause. Hormones fluctuate, periods become irregular, sleep and mood can change, and the early metabolic shift begins, unfortunately. This phase is often the most confusing because the hormones are not low, they're just unstable. Estrogen jumps up and down, progesterone falls, testosterone also jumps, and it can last several years. The second is menopause itself, and this is defined as 12 months with no period. Symptoms often reach their peak in menopause, and where estrogen will settle at a low level and stay that way. The third is postmenopause. And this is a long phase that follows, and this is where preventative medicine truly pays off. The heart, the bones, the metabolism all need our attention here. Let me say a little more about perimenopause, because this is the phase most women miss. We all miss perimenopause, again, because we attribute those symptoms to psychology or something with mental health or something with, most of the time it is mental health. But again, most women don't realize that it's not mental, that changes are hormonal. And at this time, many women, they go see different doctors for several different conditions and complaints, and nobody ever connects the dots. And I want you to know this: these symptoms are real and they are treatable. You do not simply have to endure them. Now, how do we manage this transition? The key word is individualize them. Sorry. For every woman, lifestyle will be the foundation: movement, nutrition, sleep, and stress. And we will return to this. So beyond that, treatments, again, as I said prior, estrogen, progesterone. So basically HRT, that's the hormone replacement therapy, will be very helpful for the right person. I'm not saying it's a one treatment for everybody. And this decision is going to be case by case. It depends on each woman's health history, on timing, on her symptoms, on her goals. There is no single answer that fits everyone, of course. So the message for this pillar number 1, is simple. Understand the phase you are in. Are you in perimenopause? Are you already entering the menopause? And you need to find a clinician that looks at the whole picture, not the symptom, not one symptom at a time. And that clinician can build a plan that fits you. Next slide, please. And so this brings us to the second pillar, which is proactive weight management. And I want to start with a reframe, because this is where many women feel frustrated. After 40, the body changes the rules, unfortunately. The strategies that worked at 25, at 30, often stop working here. And it's not a failure of willpower or a mental health problem, it's biology, it's our genetic. It's once we understand that it is our biology, we can work with it. Next slide, please. So why does weight management changes after 40? Let me name the main drivers that you see here on the slide, because naming them is the first step to really addressing them. And the first one is the muscle loss. As we mentioned previously, less muscle means we burn fewer calories at rest. Muscle is, I think, honestly, personally, for me, muscle will be the most important phase. And the organ it's an organ that will protect our bone, that will protect us. And muscle, let's remember, it's very metabolically active tissue. So losing the muscle slows everything down. The second is a slower metabolism. Our resting energy needs, those needs, they gradually decline with age. The third is insulin sensitivity, and over time, cells can respond less efficiently to insulin, which affects how the body handles sugars and stores fat. The fourth is the hormonal shift itself. We've already discussed that as estrogen falls, the body tends to store more fat in the abdomen. And the fifth is sleep and stress. Poor sleep and high stress can raise the hormone called cortisol, which can increase appetite and also will encourage the fat storage again around the midsection. Well, and I want to add one more thought, because this is where so much frustration lives. If you're doing the same thing you always did and the results have changed, you're not failing. The rules changed. The rules that our biology was governed prior. And that's not my fault or your fault or any other woman's fault. And it can be fixed. Also, I would like to tell a woman who goes into the perimenopause to look beyond the numbers on the scale. What matters most is the body composition, how much muscle you carry compared to fat. Two women at the same time, at the same weight, can have completely different health. So let's focus on the things that actually move that needle. And notice something, several of these drivers come back to one thing: it's muscle. Keep that in mind, because it points us directly to what works. Next slide, please. So let's be practical. On the left, if you look at the left, the strategies that support the good evidence, and on the right, the approaches I would gently avoid or steer you away from it. So let's start with what actually works. First, resistance training. 2 to 3 times a week, lifting weights, resistant bands, body weight exercises, and this is the single most powerful tool to preserve and build muscle. I cannot overstate it. Again, for me it's the most important thing. Second is enough protein. You have to spread that protein across the day. Protein at each meal supports muscle and help with fullness. Third, I would say fiber. Real food, do not restrict yourself. Fourth, it's going to be daily movement. Lifting weight is not enough. We still need to do some steps. So we need that activity. We can call it a cardio, but again, moving is very important. Fifth is going to be the sleep and the stress management. And they are, again, your sleep is a metabolic tool. If you don't sleep enough, the hormones go out of whack again as well. And I understand this could be very frustrated because I want to reassure you guys, especially those who feel that this is a lot. Like when do I say the strength training? I don't mean you have to go to the gym full of equipment and start exercising. We can start small. We can start just with our own body weight at home, maybe in the chair if needed. The key is to challenge the muscles and to be consistent. Consistency is the key here. And here's the encouraging science. Muscle responds at every age. Women in their 60s, even their 70s and beyond, they can build muscle when they train. It is never too late to begin. Really, it is never too late to begin. Start where you are. Start gently and build up from there. Now let's look at what to avoid. Which approaches I would encourage you to avoid. Avoid crash dieting. It really doesn't work because they often cost you muscle, and which if you lose the muscle, then the metabolism will slow down further, the opposite of what we want here. Also, avoid relying only on cardio without any strength work. Avoid skipping protein. I avoid chronic lack of sleep. And I avoid the idea that one plan fits all. If you remember one thing from this pillar, let it be this. Again, build muscle, protect muscle. It is at the center of weight metabolism, and as we'll see now, long-term health. Next slide, please. So now our next pillar is going to be disease prevention. 3 areas matter most as we age: the heart, the bones, and metabolism. The choices we make in midlife will echo in all 3 for the decades. And the encouraging truth is that much of this risks is preventable. Next slide, please. So let's begin with the heart, because this is the most important and most underestimated. Estrogen is cardioprotective, and I'm not gonna get tired repeating this. Estrogen is cardioprotective. Cardiovascular disease is the leading cause of death in women worldwide. Not breast cancer, as many people assume, the heart. And for much life, estrogen offers women protection after menopause. That protection fades and cardiovascular risk rises. And this is the key, much of that risk again is preventable. So what do we do? 4 things. We monitor blood pressure, cholesterol, including markers as ApoB, LDL, and of course blood sugar. We move. We combine aerobic activity with strength training every week. And we nourish. We emphasize fiber, healthy fats, and minimally processed food is possible. And we address the other factors: smoking, very important, drinking, sleep apnea, family history, and ongoing stress. Well, there's one more thing that every woman should know about the heart. The warning signs of the heart problem can look different in women than in men. They are not always the dramatic chest pain, the left arm pain, that we see in the movies, they can be quieter, often usually fatigue, shortness of breath, or discomfort in the jaw can indicate cardiovascular problem. So please take this sign seriously. I know you're a young audience, but this is just for your future. And do not talk yourself out of seeking help, and know your numbers. Ask, when you speak to your doctor, you should ask about your blood pressure, your cholesterol, and your blood sugars. And numbers you can see are numbers you can act on. If you don't know the numbers, you don't know what to do, whether they're high or they're low. And your heart will respond beautifully to the habits. So, and it's rarely too early, and it's rarely too late to protect it. Next slide, please. Next, the bone health. Bone loss speeds up in the years around menopause because the failing estrogen removes one of the bone's key protectors. So why does this matter so much? Because fractures later in life are one of the greatest threats to a woman's independence, and they are largely preventative. So how do we protect the bone? We have 4 steps. We have to load the skeleton, weight-bearing exercise, resistant exercise. It sends the signal to the bone to stay strong. Once again, strength training is the most important thing. We fuel the bone with enough protein, calcium, and vitamin D. We have to test our vitamin D every 6 months. We screen bone density, DEXA testing, and then we have to reduce the risks, again, about the smoking, about the drinking, and making the home safe from falls. Bone is easy to ignore because you don't feel how your bone gets weaker. There is no symptoms until that fall and a fracture. That is what makes it so important to act early rather than to wait. And I want to highlight one tool that is often forgotten: balance. Many serious fractures begins with a fall. So we have to train our balance. For example, you can stay on one leg while brushing your teeth. That's a great exercise. And that will, again, that's an investment to your independence in the future. And as we see, the theme repeats itself. What's good for the muscle, the same thing is good for the bone. So the same habit will protect both the bone and the muscle. Next slide, please. Yes, so the next is going to be metabolic health, the third area of our discussion. And the challenge here is that it is quiet, just like with the bone. Insulin resistance, rising abdominal fat, and we call that visceral fat, and it's very active, and slowly climbing blood sugar and all of that form a continuum. It can develop silently for years before there are any symptoms. And that is the real danger. But it also an opportunity, because when we catch it early, it is highly modifiable. A few points to understand here. Insulin resistance is an early signal, and importantly, often a reversible one. Visceral fat, the fat around the organs, it is not passive, as I said, it's active, and it raises your risks. Glucose drift, that's prediabetes. And frequently, it arrives years before you feel any symptoms. So let me make the muscle point more vivid again, because it surprises people. Think of your muscle as a sponge for blood sugar. After a meal, active, well-trained muscle draws sugar out of the bloodstream and stores it away. When we carry less muscle, that sponge is smaller, and sugar lingers longer in the blood, which is not good. It can lead to insulin resistance. So every time you train, you are improving how your body handles sugar for hours afterwards. As remember, we said that muscle is a very active organ, very active tissue. This is why the early stages of metabolic trouble respond so well. Small, consistent changes in movement and in food can turn the picture around often before it can become very dangerous. And also we have to screen very proactively. We have to check the glucose levels, A1C, lipids, and waist measurements. And the same levers we keep returning to: movement, nutrition, and sleep shift the entire picture. Let's move on to the next slide. Now I want to bring all of that together because this is the heart of how I practice medicine. Two women can be exactly the same age and yet have completely different risks, different hormones, and different goals. So a single general plan cannot serve them both well. Personalization is how we take the strong evidence I have described and shape it around one individual. Let me give you one simple example. Imagine two women, both 55. The first has a family history of heart disease and low muscle mass. The second has excellent heart numbers, but early signs of thinning the bone. They are the same age, but they need almost opposite priorities. The first should focus on the heart and on building the muscle, and the second should focus on the bone and the balance. If I gave them both the same general advice, I would serve neither of them well. So in my work, personalization follows 5 steps. First, we listen, a full history, symptoms, lifestyle, and most importantly, personal goals. Second, we measure, targeted laboratory tests and biomarkers, and a careful look at family history. Third, we stratify. We map each woman's individual risk across the heart, the bone, and metabolism. Fourth, we are going to tailor. We build a realistic, prioritized, evidence-based plan, one she can actually live with. And fifth, we're going to adapt. We measure again and again and again over time, and then we adjust because life changes and biology changes, and we have to adapt. And this is the difference between general advice and the real care. The science is universal, but the plan is not. Well, next slide, please. So let me make this concrete. What might a healthy week actually look like for a woman who is entering perimenopause or menopause? We're not trying to be perfect here. We're just trying to be consistent. Strength. 2 to 3 resistance sessions a week is a must. Movement, daily steps plus regular aerobic activity that you can enjoy. Protein and plants. Protein at each meal and plenty of fiber. Sleep, you have to aim for 7 to 9 hours. Yes, not 5, not 6. 7 is the minimum to 9 hours on a consistent schedule. And stress, a daily moment to slow down and recover. And there are so many modalities now to reduce stress. We have meditation, we have guided meditation, yoga, sound healings. There's a lot of things out there nowadays. And of course, partnership, regular checkups, and working together with your clinician. Well, let me offer one practical trick for making these habits stick. Attach a new habit to something you already do. This is something called habit stacking. For example, do 10 squats while you make coffee. Take a short walk after dinner, or try to do that every evening. Even 20 minutes, it will count towards your future self. You can also put your training strength sessions into the into the calendar, just like you have an appointment. The goal is to make the healthy choice, the easy choice, the default. That it has to be that way rather than a daily battle of willpower. So please forgive the imperfect weeks. Stuff can happen and it will happen. What matters is not perfection, as I said, it's consistency. You have to return to your pattern again and again. And please try not to change everything at once. It's never gonna work. Choose 1 or 2 things and begin there, because here's the principle that matters most. Consistency beats intensity. Small, steady choices, repeated over years, become decades of vitality. Next slide, please. So let me leave you with these 4 ideas to carry home. 1. Midlife is not the start of decline. It is the highest leverage window to protect your future health. 2. Hormonal changes reshapes the whole body, so we should manage it deliberately, not ignore it. 3. Muscle and movement. And they sit at the center of weight metabolism's bone. I cannot stress it enough. Protect them. And 4. Prevention and personalization are what turn good evidence into your lasting vitality. Before I close, I want to speak directly to anyone who feels that they have started late. Trust me, it is never too late. Maybe you feel like your best window has passed. Please hear me, it has not. The body is remarkably responsive at every stage of life. The best day to begin was maybe last year, but the second best day is today. So you do not need to change everything. You need to change one thing and then keep going. That is how vitality is built. Not in a single dramatic leap, but in small, faithful, small steps, repeated over time. And again, I will end where I began. How we age is to a remarkable degree something we build. Aging well is not inherited, it is built, choice by choice, year by year. So my dears, thank you so much for your attention. I would be very happy to take your question now if you have any. I can barely hear you. It's echoing a lot. Yes, yes. Now better, I think. Okay, I hope I understood the question correctly. So I address the first one. When a woman enters perimenopause, and that usually starts at the age of 35 and can last up to 10 years. How do we test it? We always have to test at the base, the first few days of her cycle. So when the cycle starts with the first day of the period. And so in order for us to understand the base, we usually do the blood test. We check for estrogen, progesterone, testosterone, LH, and FSH. That's your ovarian function. On the third day of your cycle. It's a baseline. They all have to be very low, usually because this is the time where endometrium sheds, the hormones are not peaking, so that's the base. The second test will be during the ovulation, because in perimenopause we're still ovulating, trust me. Not every month, but we still do. And also we have to look at the symptoms. If if a female experiencing hot flashes already in that period of time, yes, we will check for estrogen. But the numbers for estrogen is very unreliable because of the fluctuation of the hormones. So we're going to check for testosterone and progesterone. And most likely progesterone will be the one hormone that I will be giving in the beginning of the treatment, because progesterone is what regulates the mood, regulates the sleep. And we will, again, it's also personalized. It depends on the symptomology. If a woman have hot flashes already, then we have to introduce some estrogen. And I use transdermal, not in an oral form of estrogen, and it's just not estrogen, it's estriol and estrogen. It's two hormones mixed together, and we apply it as a cream. Again, the blood, going back to the blood test, the third blood test is to check progesterone, and that is checked on the 21st day of the cycle. That's when progesterone should peak. During ovulation, we also looked at FSH, because if FSH rises, estrogen have to rise too. If FSH doesn't rise, estrogen won't rise. So there are so many details, so many things to look at. You have to look at DHEA, because DHEA, if there's too much DHEA, there's going to be too much of testosterone. It's all personalized. And the second question was that about the supplements, right? I do not really recommend the supplements, because I'm not a nutritionist and not a holistic doctor. So supplements that I would recommend to my women would be probably creatine, 2.5 to 5 grams a day, because we have evidence now, there is a randomized clinical trials that creatine supports the brain function in women. And I would probably start there with creatine. Also, you have to look, now going back to the blood work, you do the blood work and you have to check for the protein called SHBG. If that number is very high, we can bring it down by taking one supplement called boron. What does SHBG do? It binds free testosterone and free estrogen within it. So once we take boron, it unbinds and the free testosterone and estrogen release into the bloodstream, and women usually feels better. I think I answered the question. It was echoing, not sure if I answered it. Have I? Sure, yes. Testosterone, you have to look at testosterone numbers during the ovulation in women. We're talking about women, right? So testosterone, do I give testosterone right away? No, I do not. Because testosterone does not protect your bones. Testosterone, it plays a role in the libido, but it does not really affect the mood. Most of the time, we have to balance two hormones first before we introduce testosterone. In my practice, I usually do estrogen and progesterone. I optimize those two, estrogen and progesterone, and then we add testosterone. And all the hormones that I use in my practice, they're not injectables, they're not oral, they're all in creams. We can introduce, or patches, for example, estrogen patch that a woman can wear the whole week, or twice, she can put the patch twice a week. But yes, testosterone plays a role, and absolutely I'm not against testosterone, but I just want to emphasize, testosterone is not the main hormone that will protect the woman from osteoporosis. Estrogen is. Estrogen is the main hormones that protected women's nature until she lost the reproductive age. As I like to say, nature used to protect the woman, but once the reproductive age is over, nature leaves, and now a woman have to protect herself by, again, taking exogenous estrogen and progesterone and testosterone. But yes, I don't want to dismiss testosterone. Testosterone does play a role, and we do introduce testosterone into the HRT after we optimize the estrogen and progesterone. No, no, I did not. I, yes. Well, sure, we can try, but it's a supplement. Phytoestrogen, it also depends on metabolites. For example, the estrogen that we need is 17 beta estradiol, and phytoestrogen is not that. Can it be? Can we supplement with that? Starting perimenopause? Absolutely. Will it work for every woman? No. But can you try it? Can you and see what happens? Yes, absolutely you can. There's no danger in it. I don't believe there is danger in it because in my practice, few women have tried phytoestrogen for at the beginning of perimenopause, but unfortunately they couldn't just continue with that because it just wasn't enough to reduce the hot flashes and vaginal dryness. Well, if the hormones did not change, then we would see it on a lab panel. We would see the blood work, but the numbers do change. Trust me. And yes, we move less, absolutely, but not everybody. I mean, I have women at 60 who are my patients, and they move more than me, and I'm 43. But yes, statistically speaking, the older we get, the less we move. But the numbers of hormones, of course, they age. Again, estrogen is released by our ovaries. Inside the ovaries, we have those eggs, and there is a hormone called AMH, and that measures ovarian reserve. So once the last egg leaves the ovary, menopause starts. Estrogen drops because inside those eggs we have inhibin A, and it inhibits FSH to going very high, and it helps the estrogen to stay stable. So once the eggs are gone, stability is gone and estrogen drops. Yes. Yes, but again, metabolism changes because of the hormonal decline, right? When you're 35 and your hormones are fine, or you're 30, your metabolism is fine. So everything's connected to women hormone, to those three hormones. And that's why it affects, for example, why do postmenopausal women who are not on HRT, not on hormone replacement therapy, have very high cholesterol. And I tell you why. Because your liver makes cholesterol to make hormones. Once your hormones are gone, you don't need that much cholesterol, but your liver doesn't know that the hormones are gone. So it's still making the cholesterol to synthesize the hormones, but synthesis has halted. That's why lipid management is very important after the menopause. And once we introduce estrogen, the liver stops making so much cholesterol, so the lipids drop. So when we give estrogen patch, the lipid profile drops within 3 to 4 months. It depends on your, again, it all depends on your cardiovascular risk profile. You look at those numbers as ApoB or little a. ApoB measures how many LDL particles you have inside of you, and lipoprotein little a shows your genetic predisposition. If that number is high, it means you're genetically predisposed to higher cardiovascular risk. Thus, you need to look at your diet. We cannot be fat-free. Women do need fat, especially during menopause. We do need fat because the estrogen that you're going to put on yourself, it has to go into your fat tissue. If there is no fat tissue, it's very hard for the estrogen to actually do its job. Do we need to decrease saturated fat? Yes, but introduce healthy fats. We can change or exchange unhealthy fat to healthy fat, but fat-free diet is not an option for women after 35. Absolutely. And that's a very important question, and thank you for that question. Not every woman would be a candidate for the HRT. For example, women with a history of breast cancer or uterine cancer are not a good candidate for HRT. They are the candidates for progesterone, but not estrogen. We can always give progesterone alone without any other hormones, but we can never, never give estrogen without progesterone. Because if you remember, I'm not sure if you do know, estrogen's main job is to proliferate the endometrium tissue. And progesterone's job is to tell that endometrium to stop proliferating. So that's why women who had uterine cancer, the mechanism is broken. So the estrogen would be not an option for them, unfortunately. In that case, there are other medication, not hormonal, that can relieve the symptoms of menopause with hot flashes, antidepressant, sleep medication. But estrogen, why do we talk about estrogen? Because it's the only modality that can protect your bone. Osteoporosis 100% correlates with fall in estrogen. But again, women with prior cancers, with fibroids, with a lot of uterine fibroids, unfortunately, they're not the candidates for the HRT. Some women with chronic migraines also probably not the candidate, but we can try. We can start very low, and we can titrate it up. But number one contraindication would be prior history of malignancy. Right. Right. So the strokes, insult, right? That's what insult is a stroke in English. So why there is a risk of a stroke? Because like with any contraceptive, estrogen replacement therapy carries the risk of blood clots. Absolutely. And again, we can counteract that with taking aspirin. Again, we have to, the blood work, that's why the blood work is very important. My patients usually do blood work 3 times a year, and we look at the thickness of their blood. If the blood getting too thick, because on estrogen, not so much of thickness, but once we add testosterone, and that's very important, that's why many men on testosterone replacement therapy do phlebotomy. They do the blood pooling, how do you call that? And that's what testosterone. So if you combine testosterone with estrogen, your blood becomes more thicker, and you have to look at hematocrit, hemoglobin, the red blood cells itself. And there is a potential risk of a stroke, absolutely, and a migraine. The thicker the blood, the worse it is for your head. All right. Thank you so much for having me. It was again a real privilege. Thank you, guys. All right. Thank you. Have a great evening, everyone. Bye bye. All right. Да?